All right, thank you for keeping it Ebro TV, and now we are about to go into our discussion on matters health. Something I usually like to say is that health is better to you as an investment rather than as an expense. My name is Emmanuel Kutosi, and don't take my word for it. I am joined by George Osoro from the NHIF, and he's going to give us everything about him, and I will invite him to the program now to be able to tell us his name, his and everything that concerns universal health coverage.
Thank you, Kutosi. For purposes of our viewers at home, my full names are Gilbert Mogambi Osoro. I serve as manager, Universal Health Coverage, acronymed UHC. And UHC is domiciled in NHIF. Before we start, let me first of all bring greetings from our CEO and the Board of Management of NHIF, who sent me to represent them here. At NHIF, we say that Afya Bora Bima Tosha. So I want to tell our viewers at home to feel welcome, and we want to break it down to them. One of the things that I note is that our members may not know the scope of cover, which is very generous, that is administered by NHIF. I want to use this opportunity this morning to break it down in a layman's language. My Bible tells me that my people perish because of lack of sufficient knowledge in the book of Osoro 4 verses 6. Thank you.
Okay, and since you are already into it, perhaps you can give us about the journey on medical pun intended. Give us the pulse of UHC from its beginning to at this very moment in 2023 today. How far has UHC come? If you were to check the pulse, where is it?
Now, they say this, that the further you look into the past, the further you see into the future. Allow me to take you through a historical journey on establishment of NHIF. NHIF was established way back in 1966 as a department in the Ministry of Health. What happened in 1965, there was the cabinet meeting that came up with secessional paper number 10, which was the blueprint for development in this country. Among the key things that the secessional paper number 10 noted was that for us to be able to progress as a country, we had to put or cover members of the then civil service and citizens of this country. In 1966, the then Legislative Assembly passed Cap 255 laws of Kenya that gave birth to NHIF as we know it. At the passage of Cap 255, NHIF was led by a volunteer board, and the premiums were that anybody earning above 1,000 shillings was by law required to remit only 20 shillings to be a member of NHIF then. The benefit package that was administered then was inpatient treatment. And for a very long time, Okutos, you might have heard people alluding to the fact that NHIF inalipia tu kitanda. There's been that school of thought. Now, in 1972, there was an amendment to the NHIF Act, that is Cap 255 laws of Kenya, to allow members who are self-employed. When I say self-employed, I insinuate farmers, juakali artisans, retirees, house managers,
The informal sector,
to be members of NHIF. And they were also to contribute 20 shillings. And the benefit package that they were to access was inpatient treatment. We continued administering that act until 1998, when the then Minister for Health, the late Emilio Stanley Mwai Kibaki, moved a motion in Parliament to amend Cap 255 laws of Kenya into the NHIF Act number 9 of 1998 that transitioned NHIF from being a department in the Ministry of Health to a state parastatal, which is a quasi body that had its own board. And the other thing is that it enabled NHIF to run its affairs. The transition was partly informed by the decision to improve efficiency and effectiveness. Now, after we became a parastatal in 1998, the other key milestone was in the year 2012, whereby the then government decided, as part of its obligation towards its servants, civil servants. Remember that healthcare is a constitutional requirement. When you read the provisions of Article 43, it's Article 1, which reads that all Kenyans are entitled to the highest attainable standard of health, including reproductive health. They are also entitled to emergency treatment. In fulfillment of the Constitution and the Labour Act, the government procured a comprehensive medical cover for civil servants and the National Police Services, that is discipline services, which was comprehensive in nature. That was a key milestone event because for the first time, NHIF was able to roll out the outpatient benefit package, whose provider payment mechanism is known as capitation. When we talk of capitation, the definition of capitation is that NHIF procures healthcare services for a segment of population in advance. I'll later on talk about the outpatient benefit package when I shall come back and talk about the 10 benefit packages that are administered by NHIF under the super cover benefit package. Now, from 2012, there was also a major milestone in 2015 whereby NHIF rolled out the new rates. Remember, we had remained with the same rates from 1998 up to 2012. This was partly guided by the rising cost of living, inflation, and the population needs and the disease burden for Kenyans. So in 2015, after Parliament ratified the new rates in in April, NHIF embarked on increasing the length and scope of the benefit package. It witnessed for the first time introduction of the outpatient benefit package for the informal sector. Previously, it was only for people in gainful employment, that is civil servants, who had procured a comprehensive cover. There was also the introduction of other benefit packages during that time. We had the diagnostic imaging, MRI, CT scan, and others. We had introduction of the surgical benefit package, which is highly patronized. When I talk of surgical benefit packages, it's segregated into minor, major, and specialized organ transplant. The other key event was in 2018 when the then Cabinet Secretary for Health, Honorable Cicely Kariuki, established a task force that was to review and align NHIF to UHC attainment. In 2018-2019, remember there was the UHC pilot that was undertaken in 4 counties. We had Nyeri, we had Kisumu, Machakos, and Marsabit. Now, Kenyans felt that a time had come to review the benefit package that was administered by NHIF. The task force that the Cabinet Secretary set up was known as the Health Reform Expert Panel, in short, HEFREP. The HEFREP came up with a report that was known as the NHIF We Want, that was to transition NHIF to be the vehicle through which the government will attain UHC. So it led to, among others, the reforms that you are currently seeing. As you are aware, on 10th of January 2022, His Excellency, the former president, did apprehend his signature to pass the NHIF Amendment Act of 2022. The commencement date for that particular act was on 28th January 2022. The act came with very many reforms to align NHIF to UHC. In a nutshell, as we speak, currently we are implementing the NHIF Amendment Act 2022, which has the sole objective of aligning NHIF to UHC attainment. Yeah. And
looking at the fact that you've told me there are several acts that were made before. Now the NHIF Act 2022, among the things that I noted is that from the National Hospital Insurance Fund, there was an alteration to the National Health Insurance Fund. And there's also a report from the Cabinet Secretary of Health that at around July this year, it will be changing names to the National Social, I believe, Health
National
Insurance.
Social Health Insurance Fund.
Yes, I find an intent rather of trying to break the idea that NHIF is locked on the hospital aspect, but rather it's widening out into the matters of healthcare for Kenyans. My question is, so far, how have you been able to even change the whole narrative concerning NHIF in matters of increasing subscriptions among Kenyans?
Now, perhaps allow me to take a deep dive on the effect of the NHIF Amendment Act of 2022 that transitioned NHIF, aligned NHIF to UHC rather.
Proceed.
The effect, number one, was the change of name from the National Hospital Insurance Fund to the National Health Insurance Fund. The purpose of that particular clause was to expand the mandate of NHIF. Previously, we were only confined to dealing with hospitals. But in the new revised act, it provided room to empanel and contract professionals, healthcare professionals. Apart from hospitals, in future, we will contract consultants, pharmacists, and others as we go on. It's works in progress. Number two was to ensure sustainability of NHIF. We came from a dispensation whereby it was erroneously assumed that NHIF was the primary insurer for people who had another insurance cover. You might have heard that each time for people who have another insurance cover, whenever they go to hospital and they are treated, at the point of discharge, the providers first indicate that NHIF should take the first loss, pay the bill for whatever they can, then the insurance company, the secondary insurance, tops up the bill. To ensure sustainability of NHIF, the new NHIF Amendment Act has made it very clear that if you have another insurance, then at the point of discharge from hospital, the other insurance will take the first hit, or they'll first pay. Then NHIF will come and reimburse the rebate or the outstanding amount. The other effect of the act was to improve on governance and enhance representation. The composition of the board was revised to encompass all key players in the healthcare ecosystem. We, for the first time, provided for the Council of Governors, who are key stakeholders when it comes to healthcare. Remember, healthcare is a devolved function pursuant to the provisions of the new constitution that we promulgated in 2010. So for the first time, we provided for 2 board members appointed by the Council of Governors who are not governors themselves. Number 2, we involved members of the public, in the sense that the Cabinet Secretary for Health was given power and authority to nominate 2 board members who are specialists in accountancy, law, insurance, medicine, to join the board to bring that much needed expertise to NHIF. We also have members of the Kenya Medical Association, Federation of Kenya Employers, KOTU, amongst others, being board members of NHIF. The other aspect was that to ensure that the gains that have been achieved over the years are not eroded, the Act made it mandatory that we will not revise the benefit packages that have been rolled out to the detriment of our members. So, and it also provided for review of the benefit packages after every 2 years. Remember, the new contract cycle was rolled out on 1st July by the former CS, Honorable Mutai Kagwe, and it was meant to last for 24 months. As we speak, the new contract cycle is in its 7th month. So it will provide for, amongst other things, review of the benefit packages, and they'll be subjected to actuarial simulation. What we are saying, going ahead, benefit packages will be informed by utilization and the data that we collect in our database, amongst others.
Okay. And according to the Act, everyone should be onboarded. The Ministry of Health has trusted NHIF as the one vehicle that will move UHC going forward. Several partners within the medical industry, including KMPDU, have actually been among those who have actually lobbied for NHIF as the best ship to ensure UHC goes out to the whole part of the country. Now, as one who is managing universal health coverage in Kenya, can you say that NHIF is ready? And if so, how? Communicate to the common mwananchi. How are you ready to actually ensure that even after all this backing from these ends, we will get where we are going?
Thank you. As you've clearly indicated, the amendment, the NHIF Amendment Act, made it mandatory for all Kenyans who've attained the age of 18 years and above to be members of NHIF. The Act also provided for those who cannot be able to afford healthcare premiums be identified and be subsidized or paid for by the national government. Now, what is NHIF doing, as you've asked, to show that it is ready for the rollout of UHC attainment? Remember, the HEFREP report recommended 55 recommendations to transition NHIF as the vehicle through which the government will attain UHC. Among the other things that it recommended was legislative reforms, and the NHIF Amendment Act has been passed by Parliament and accented to by the President. The other thing that it recommended for digital transformation. As you are aware, NHIF is actively undergoing digital transformation. Towards that end, you may have witnessed in the year 2020, NHIF rolled out biometric enrollments and identification of indigents. The HEFREP report noted that there were gaps with the physical identification, whereby members used to produce copies of their national IDs and a birth certificate for purposes of accessing healthcare. To close the gap, the committee recommended that NHIF adopts biometric enrollment and identification of members for purposes of increasing efficiency, effectiveness, and curbing fraud, wastage, and abuse. Remember, from the reports that we received from the regulator, that is the Insurance Regulatory Authority, fraud is a monster that is an impediment to access of healthcare. And the conservative estimates put it at around 25% of the claims that are paid out by providers are actually fraudulent claims. So to close that gap, we did roll out the biometric identification and electronic health records. Currently, we have onboarded all private facilities in level 2 up to 6 and all government facilities in level 4 up to 6 on the eClaim platform. And when I talk of providers that are onboarded of NHIF, we have in excess of 8,039 healthcare providers that are empaneled and contracted by NHIF. The good news is, to align ourselves to UHC attainment, we realize the critical role government facilities will play towards attainment of UHC. Out of the 8,039 healthcare providers, 75% or in excess of 5,800 are GOK facilities owned by the national government and the county governments, followed by 2017 or 21% of facilities that are owned by private providers. Lastly, not the least, we have around about 339 healthcare providers, or 4%, that are owned by faith-based institutions. So towards that end, in the new contract cycle, the Department of Provider Management sought to empanel and contract all government facilities in this country. So Kenyans can be rest assured that they can access services. And when I talk of services, it is the UHC Super Cover Benefit Package across the 8,039 healthcare providers that are impaneled. The other thing is that we have a robust branch network. NHIF services are available at 156 service points. We have 70 branch offices that are distributed in the 47 counties. We have 53 satellite offices that are also in the sub-counties. And I want to report that we have 53 points of services at the Huduma centers, making it 156 points of service. So Kenyans can access services across all the territorial boundaries of this republic. The good news is that the branch networks are connected through the use of ICT. We have a robust ICT platform that ensures that all points of services are interconnected. The other thing that NHIF is doing to align itself to UHC attainment, we have the current implementation of the new organizational structure and the right placement that is ongoing. Remember, in 2020, the Board of Directors did submit to statutory SCAC, State Advisory Committee, the instruments, the HR instruments, that is the organizational structure and HR instruments for purposes of aligning NHIF to UHC. The organization structure was ratified by the full board meeting that was held in 30th September last year, and we are, as we speak currently, we are at the tail end of implementation of those instruments to align ourselves to UHC attainment. The other thing that we are doing to ensure that Kenyans get value for money, the HEFREP report recommended that NHIF transition from being a passive purchaser of healthcare service to strategic purchasing of healthcare services. And when we talk of strategic purchasing of healthcare services, we have to look at three things. One, we look at the population needs of a country. What do Kenyans require? At NHIF, we say that the customer is the king and the customer is always right. So we did a baseline survey to ascertain the needs that Kenyans require in terms of healthcare. And there was a team that went around the country. If you recollect, in 2019-2020, we had the Health Benefits Advisory Panel, which is acronym HPAP, that was led by the able Professor Gilbert from Strathmore University and team that went around the country picking feedback from Kenyans on what they felt should be captured in the UHC Essential Benefit Package. And it's that is what informed the benefit package that we are administering today. Now, when it comes to strategic purchasing, one of the things we consider is that we must purchase healthcare services taking into mind cost effectiveness. We want to harness the benefits of bulk purchasing. So in this new contract cycle, we ensured that there is value for money. We procured services in bulk and the benefits were transferred to Kenyans for purposes of increasing the length and scope. In the new contract cycle, in line with UHC, which is ensuring that the entire population has access to affordable, accessible, quality health services that are preventive, promotive, rehabilitative, and curative, we sought to embed the preventive, promotive aspect in purchasing of healthcare services.
How did you do that?
Towards that end, we ensured that for the first time, for the outpatient benefit package, whose provider payment mechanism is known as capitation, we allowed facilities at primary care level, that is in level 2 and 3. When we talk of level 2 and 3, we talk of health dispensaries, healthcare facilities, that is dispensaries, and health centers at Mashinani. Remember, this new Kenya Kwanza administration, as part of the government manifesto, said that there should be a deliberate paradigm shift from investment in curative healthcare, which was taking 45%, to preventive promotive healthcare, whereby a shilling in preventive promotive healthcare will save an equivalent of 9 shillings when we do clinical interventions at a later stage when patients are sick, in stage 3 or 4, for example, in cancer. So to do that, we have embedded screening. We are talking of, for breast cancer, which has been declared a national disaster, we have embedded specialized ultrasound as part of what will be administered as primary health care. We have embedded mammography, which is the test to detect any presence of breast cancer. We are looking at issues like end-stage kidney disease that are prevalent now. You might have noted that the third highest cost driver when it comes to the benefit packages in NHIF is the dialysis benefit package, whereby in recent years we have witnessed a number of Kenyans being treated for end-stage kidney disease. Whereby I did mention when we started this show that for the dialysis benefit package, NHIF reimburses comprehensively 2 sessions of dialysis at 9.5. If you calculate cumulatively, that is 19,000 in a week. In a month, it's 76,000. In a year, we are talking of 996 or 1 million Kenya shillings from the 500 shillings that our members contribute. Instead of paying $1 million, we are saying we will introduce annual medical checkups at these primary care facilities that will, among others, check what is known as the liver function test, so that we do not treat you and spend $1 million, but rather arrest illness before it comes catastrophic, amongst others.
You've given us the whole breakdown of what NHIF is doing to ensure that coverage goes to each and every Kenyan. And among the things concerning universal health coverage is the fact that to attain it at 100%, it's more of a combined effort among all the stakeholders. That means the people, that means the service providers, and even the government as a whole. Now, my question is this. When you're looking at the private sector, it's not one that you could really put aside. However much the government hospitals have been onboarded into NHIF and all, what is the role of the private sector in facilitating UHC, and how are you accommodating it?
Very important question. As you've captured it, healthcare, provision of healthcare is not confined to government facility, or is not a functionality of government. It encompasses the entire healthcare ecosystem. We are looking at the government, we are looking at private providers, and when we talk of private providers, we are looking at faith-based institutions. We are looking at private hospitals. We recognize the key role the private healthcare, private sector does to complement the government effort. Number one, as I mentioned when I spoke about empanelment, we have in excess of 2017 private healthcare providers that are empaneled and contracted and spread across the 47 counties in this country that offer services to NHIF members. We are also looking at the 339 faith-based organizations that are owned by churches, mosques, that offer services to NHIF members. They also support us in the sense that they do sensitization on the scope of the benefit package. They sensitize our members. They also complement NHIF when it comes to biometric enrollment. Remember, when we roll out biometric enrollment, apart from NHIF branch network, enrollment is also being undertaken at the point of accessing services, including the private and faith-based institutions. When it comes to issues of benefit design, and it's a requirement of the law that we get feedback from our members of what they want captured in the scope of benefit package. Among the people who put in submissions that informed the current benefit package were private healthcare providers, and we want to salute them because they've been solid partners as we journey along towards 100% attainment of UHC.
Yeah. We've talked about value for money. UHC is supposed to ensure that Kenyans get value for their money. When we extend out into the private sector, how are you ensuring that there is more of a standard quality, that if mwananchi goes to a public hospital, the quality of treatment they receive, there is not that much disparity from the treatment they would receive from a private facility? How are you ensuring that even as you facilitate the treatment of Kenyans, that there is a standard quality, that what you have paid for is quality for the common mwananchi, regardless of where they access health services?
Very important question. Now, I did mention when I defined UHC that it's ensuring all people have access to affordable, accessible, but the big one, quality healthcare. Underline the word quality. And what we've done in terms of quality at NHIF, we have a full-fledged department that is called we have the Department of Provider Management, which has a division that is known as Quality Assurance Division. Now, the functionality of that department is, one, to accredit healthcare providers having inspected and confirmed that they meet the threshold. Remember, the functionality of empanelment was removed from NHIF and taken to the regulators, the Kenya Healthcare Professional Oversight Authority, that is KHPOA, the Kenya Medical Practitioners and Dentists Council, and other professional bodies pursuant to the Section 30 of the revised NHIF Amendment Act. Now, to ensure that whatever we empanel meets the expectations of Kenyans, these professional bodies are part of the teams that undertake due diligence to confirm beyond reasonable doubt that the facilities that are being contracted to offer services meet international standards. But having said that, it's not enough to contract. Remember, healthcare is a continuous process. Inspection is a one-off event. At NHIF, we have quality assurance officers who are in all our branch network. These quality assurance officers are clinical officers, nurses, and other medics who undertake due diligence to confirm that the treatment plans that are being administered to our members are, one, meet the standard operating procedures, the SOPs. Two, the quality of care is not compromised. And the new contract cycle requires healthcare providers to hold what we call work improvement teams, acronym WITS, where matters of quality are discussed for purposes of improving the outcomes of care.
Now, in breaking out the whole UHC concept, health in Kenya has been more of a debate between the haves and the haves not. You find that since I consider my status maybe financially to be on the lower end, I view this as not something that I ascribe to. It's not something for me. How would you bring this concept down to each and every Kenyan to understand that UHC is here for each and every Kenyan? How have you been able to break into those fragments within society that it's not deserving of me, or I do not qualify for this? How have you been able to do this?
I'll look at it from two perspectives. One is the NHIF Amendment Act that first of all obligated all Kenyans to be members of NHIF. And two, the act made it mandatory for those who cannot pay to be identified and be subsidized or sponsored by the national government. So in a nutshell, all Kenyans, irrespective of their status in society, must be members of NHIF. The philosophy behind it, and to break it down for each of our members, is that the rich support the poor, the young support the elderly, the strong support the sick, the invalids. And what we are saying at NHIF, for us to attain universal health coverage, there must be equity in access. Remember, Section 3 of the Constitution of Kenya says that no one should be discriminated on the basis of race, gender, sex, or income. So the government has put into place mechanisms to ensure that no one is discriminated when it comes to access to healthcare. Secondly, in the new contract cycle, we set out to harmonize reimbursement rates across all cadres. In the recent past, NHIF used to reimburse providers separately and based on local arrangements. But in the new contract cycle, in line with UHC attainment, we harmonized capitation payment. For example, for all providers in level 2, 3, we reimburse for purposes of capitation, that is the outpatient benefit package. We standardize the rate at 1,000 shillings. For facilities in level 4, whereby we have members who hail from chronic ailments, who are referred from the primary network facilities, we reimburse comprehensively at 1,400, irrespective of ownership. Same case to other benefit packages. We are looking at diagnostic imaging, whereby an MRI is at 9,600, CT scan, dialysis, it's standardized irrespective of the facility you access. And in line with the Kenya Kwanza manifesto, going ahead, we will reimburse as per what we can finance sustainably, irrespective of the CAF level of the facility. Yeah.
All right. In case you're joining us at this very moment, we are in a health discussion and we're joined by Gilbert Osoro, the manager of UHC at the NHIF, and we are breaking down on matters concerning the whole universal health coverage. And Osoro, we have talked about so much. Among the key factors is that it is mandatory for every Kenyan to be onboarded on NHIF.
Yes.
What do I require? Do I require a certain amount of money to be there? What really is required for me to become a member? Because according to the latest statistics, we have 25.36 Kenyans above 18, that is million, who can be able to be onboarded. Yet the amount of, and within the latest statistics, was around 15 million Kenyans who are onboarded. What can be done? What do I need?
Now, very important question, Kutosi. We at NHIF have made it very simple for you to join NHIF. One, you can choose to go to the nearest point of service, the 156 points of service, complete an NHIF2, which is an application form, submit a copy of your national ID. If you are married, remember ours is a family-based cover, you bring a copy of ID for your spouse, a marriage certificate or an affidavit from a commission of oaths. If you have children in that particular marriage, for children below the age of 6 months, you will submit a birth notification. For children above the age of 6 months, it's a requirement that you submit a birth certificate. That is one.
And before you go very far, I'm going to come to the local setup of the way Kenyan households are. What if you're not really in a marriage in a conventional way? What happens to such families?
I know you're implying, come let us stay.
You have said it.
Now, remember, there is the Marriage Act, I think, of 2019 that made it mandatory for all unions to be registered as a matter of law. So for us to be able to recognize your partner, you must submit the requisite document, a marriage certificate or affidavit, for us to be able to onboard your spouse.
And concerning the whole registration process, you've told me of 156 centers across the country.
Yes.
You're also boarding people at health facilities.
Yes.
We are talking about family. Family comes with reproductive health.
Yes.
A question concerning Linda Mama. Tell us about it and tell us how it has been now encompassed into the whole cover.
Very important question. Linda Mama is one of the donor-sponsored programs. When I say donor-sponsored, it is funded by the government of Kenya. the program targets expectant mothers across the territorial boundaries of this country. Any expectant mother can be able to dial *155# and be onboarded to access Linda Mama benefit package. Now, Linda Mama is administered in government facilities, some private facilities, and faith-based institutions. It caters for the entire spectrum of pregnancy, from the antenatal care, where we are talking of 4 visits, we are talking of the actual delivery, and we are talking of normal delivery, which is known as SVD in Medical Palace, or cesarean section for surgery. Then we have the postnatal care after delivery. We also provide for 4 visits that are provided for under Linda Mama. So the good news is that the government has retained the Linda Mama benefit package. Remember, Linda Mama is not an insurance, it's a revolving fund, whereby NHIF receives claims on behalf of the government of Kenya, and the central government reimburses NHIF to pay providers who offer that service. And it's for all persons who are residents in this country, irrespective of whether they've not attained the age of 18 years and above. Yeah.
And we are still on the aspects of family. It's not strange within the African setup, the Kenyan setup, to find a man or that has several spouses. The conventional idea that you've sold to me now, I'd like to know, what if someone has another spouse? How do they onboard them within the cover?
We appreciate that under the context of NHIF, we recognize a monogamous marriage. But we have made provision, and what we are saying, if you have additional spouses, you can be able to enroll them to NHIF by procuring another cover, the super cover benefit package for your spouse, and they'll be entitled to the 10 benefit packages that are currently administered under the super cover benefit package. Yeah.
And the digitization process, we've talked about biometrics, which means it's more of your fingers and something, yeah?
Yeah.
What happens to those who had a card before and maybe they've not been able to go for the biometrics? Does the biometrics now make the card inconsequential or rather invalid?
What we are doing at NHIF, we realize that we cannot overnight enroll Kenyans. What we've done, we've provided a platform that all the empaneled and contracted healthcare providers are enrolling members at the point of seeking service. We have enabled the branch network and the satellite offices to enroll members at the point of them coming to register. So we realize that we may not be able to attain 100% enrollment, but what we are doing is a phased approach, whereby at the point of either accessing services or enrolling to NHIF, we capture your biometrics. So it's works in progress. And I want to use this particular opportunity to appeal to our viewers back at home. I humbly request you pay a visit to any of the NHIF branch offices, or at the point of accessing services, kindly ensure that you enroll your biometrics. And there are benefits that accrue from biometric enrollment and e-claim. Because in the unfortunate event you're involved in a road traffic accident and we are not able to identify you, through your thumbprints we can be able to tell who's a member of NHIF. Yeah.
And also you've mentioned about cancer and brought my mind back to the fact that you actually commemorating World Cancer Day the other day.
Yes.
And the health years, Susan Akumincha, revealed that there are talks to reduce the premiums being paid to be part of the cover. Perhaps you can give us a peek into the progress into the talks concerning this.
Yeah, what I like to say, indeed, the new administration promised to review the benefit structure with a view of affording Kenyans affordable and flexible premiums that are mwananchi friendly. Yes, we are looking at a shift from contributions that are pegged from individuals to households. There is also a look at the current premiums that we are administering for the super cover benefit package to come up with what I call affordable premiums. So it is works in progress. I want to confirm that indeed there is an ongoing review. In the fullness of time, Kenyans will be informed of the outcome of the reviews.
Okay, and before we had this conversation, I did share with my people online concerning the topic, and among the questions that came my way was, what of treatment abroad?
We do administer what is known as overseas treatment. Allow me to take a deep dive on what is overseas treatment or foreign treatment. Among the 10 benefit packages that super cover members are entitled to is overseas treatment. This benefit package is eligible for Kenyans who've been referred to by a consultant that they need to access specialized treatment in other jurisdiction, and one of the areas that Kenyans tend to patronize is India, because it's affordable and the environment favors Kenyans because they speak English amongst others. So for you to be eligible for that benefit package, you must submit a comprehensive report completed by the attending consultant. And I want to underline the word consultant because it's not anybody who can refer a patient overseas. It's only a consultant. For example, for cancer, we are looking at an oncologist. So they must complete that overseas treatment form indicating, one, the nature of treatment rendered so far, the diagnosis, and reasons why they feel the treatment is not locally available. You should travel abroad. The other thing, you must obtain what we call as a no objection letter from the Office of the Director General of Health, the DG's office. We look at your medical report, and if they feel that the treatment you are seeking is not locally available, they'll issue that no objection letter. The other thing you need to submit for you to travel abroad is verification from the Kenya Medical Practitioners and Dentists Council that the referring consultant is a member of regular and good standing who has renewed his annual practice license. You will submit those documents to the NHIF Overseas Treatment Office that is at 8th floor, whereby having fulfilled all the requirements, you will be eligible, of course, to travel to India as per policy and the guidelines based on the severity of or nature of treatment you are seeking. We will approve up to a maximum of $500,000 for overseas treatment.
Yeah. And we have to finalize it at this moment. So I'll allow you to call out Kenyans, because you are the manager of this whole program. Call out to them and tell them why they should be part of it, because we still have quite a number, around 10 million, who still need to come on board. Talk to them.
My call to action to all Kenyans who are watching this program is to request them to subscribe to NHIF and complement the government effort of attainment of UHC. Mahatma Gandhi, who's my favorite philosopher, once said that true health is wealth. And in the new NHIF Amendment Act, which says that those who can pay should pay, those who cannot pay, let them be identified and be subsidized and paid for by the national government.
Indeed, true wealth is health. I couldn't put it better, and thank you for taking your time to be with us right here on Ebru TV. My name is Emmanuel Kutosi, and in studio we were joined by Gilbert Osoro from NHIF, the manager concerning matters universal health coverage. And a call out to you to ensure you are part of this, because believe it, your health is an investment that you need to invest in. Thank you.
Thank you.